be available. While we're getting the questions together, I wanted to maybe kick off some of the questions with the panelists. Both Amber and Dr. Skeen mentioned what effectively is what we refer to as a triple aim of healthcare nowadays through the Affordable Care Act, which is, I guess, different definitions depending on who you talk to, but essentially it's better quality, better service, perhaps better access, and lower costs. Now, in management circles, that's referred to as the iron triangle. The reason being is that once you peg a level on any one of those areas, there is an unavoidable consequence to the other levels. You improve quality, you have to increase your price. You improve service, you have to increase your price. If you lower price, you necessarily have to lower the quality. And you can see this in some obvious areas like hotels. You know, if you're going to stay at the Ritz-Carlton, you got to pay for it. However, if you want a lower price, maybe you stay at another hotel. So my question to the panelists, can we have it all? Is it possible to achieve the triple aim?
Well, I think there's an important element that was, I think, debated when the triple aim...
I'm sorry, I can't hear you.
There was an element that was considered when Don Berwick created the triple aim that wasn't incorporated, but that many folks think is integral to achieving the triple aim, and that is patient and family engagement, and recognizing the role that patients and their caregivers have as part of this equation. So this can't just be done from the provider perspective, from the perspective of communities. It has to be patients and their family members being engaged in their care, and that means making information more available for consumers, educating them, providing them with health literacy, and taking a role. And we are seeing that. We're seeing a rise of a consumerism. Folks, they have more gadgets on their phone, on their iPads and so forth, and they want to learn more and be a part of their health care. So I think that's an important element in achieving the triple aim.
Dr. Skeen or Dr. Thorp?
So I agree with Amber about the importance of engagement of consumers in their own healthcare. One of the big challenges, I think, is that it isn't just having an app on your phone, though. I mean, there are some people who use apps on their phone, but probably, most of the people who are accessing healthcare don't utilize that in that way. I mean, young people do, but most of them are not daily accessing healthcare. What the challenge is how do you help someone who's been smoking for 35 years quit smoking, or someone who's been smoking for 10 years quit smoking? We have to find ways to help engage people in a way that they will understand that. And some of it has to have to do, I believe, with having some incentives. And some of those may be negative incentives for people who are, how do you get people to lose weight if they're significantly overweight? We all struggle with that. I struggle with it personally. But at some point, it has health consequences. So your diet has consequences. How much alcohol you drink has consequences. We've got to figure out a way to engage people in meaningful ways that allows them the opportunity and gives them the incentive and the motivation to help them change those behaviors. We can't do it by just handing out a flyer at the office. I've definitely learned that.
Skeen?
Well, I would just make the point that that access to healthcare underlies pretty much all of their social justice kinds of issues that we're facing. So, for instance, homelessness is an enormous problem, and homelessness, it's estimated that 1/3 of people who are homeless perhaps have some mental issues they're dealing with. Others may have substance abuse problems, and others are just on a low economic scale and they lost their job and fell into homelessness. And then issues with many other health issues that we're dealing with and many other societal issues are going to benefit if people can just access services on both treatment and prevention.
Okay.
So under the Affordable Care Act, they created the Center for Medicaid and Medicare Innovation. And this is where the incubator for a lot of patient engagement initiatives is taking place. So just a small example is the Medicaid incentives for the prevention of chronic disease. So our state Medicaid program is focusing on reducing smoking by providing small incentives, by engaging folks through text, and having that dialogue. And this was funded under the Affordable Care Act with the recognition that patients have to be a part of the solution.
Thank you. We've got about 10 minutes for some questions, so I'll try to get through these. This is for Dr. Thorp, but I'm sure anyone else can chime in. I think on the graphs, it loomed large that Colorado was able to lower their premium costs by such an amount. So the question for Dr. Thorp is there a correlation between states that did not expand Medicaid and or develop their own exchanges and those with higher increase in coverage premiums? What did Colorado do right to reduce premium costs? Or do we know?
I'm not sure that I can answer why Colorado's is so low, except that, you know, everybody in Colorado is healthy. Well, that's probably not true, but I do think that there was a correlation between those states that did embrace the expansion, having lower or very slow increase in costs, as opposed to the upper tier, where most of those states that had higher costs were states that did not embrace the expansion.
Thank you. Any other comments? All right. Amber stated Medicaid covered California and perhaps a reference to CalPERS were beginning to align payments to doctors. Can she elaborate on the CalPERS component?
So CalPERS had an initiative on the knee replacement surgery. So a lot of these folks, so CalPERS, Medicaid, and the exchange will start to align their quality improvement initiatives as they recognize that they are the largest purchasers in the state. So CalPERS has historically done that, and they've partnered with large purchasers as well. Medicaid and Covered California are doing that. Covered California in their health plan contracts are requiring plans to report on their quality improvement initiatives, which will then get passed down to the providers. Covered California is also including a quality rating system on its website. So consumers, when they go to select their health plans, they can go and select information based on which health plan has the highest rating based on patient care experience and reported experience and CAP scores and so forth. And so we're going to see a lot more alignment with those programs in the coming years. And so I can anticipate that we will see a lot more quality improvement amongst the entire healthcare system in California because of that.
Thank you. I'm not sure this may be a good question for Dr. Skeen, but relative to the National Health Program reference, there's a question here regarding the ramifications of the drop in reimbursements under the Affordable Care Act to specific providers. And a question, would single payer be a solution to this?
Yes. Yes. Under a single payer type system, the single payer entity, which of course in this case would be Medicare, negotiates rates with all providers, physicians, hospitals, pharmaceutical companies, and presumably those negotiations are supposed to result in what the provider groups consider fair reimbursement rates. And there are examples in many other countries around the world where this works out quite well.
Thank you. Any other comment?
Well, currently in Medicare, there is no negotiation in physician rates. It's basically the rate that Medicare sets. There's no negotiation. So, and in fact, it's against the law for us to negotiate. So there are some challenges. I do think the ideas of simplification, finding ways to do things better makes a lot of sense. But I think that there are some real reasons why a single payer has not been the solution that everyone has embraced so far.
Thank you. In a previous presentation, it was pointed out that in countries with single payer, the government only pays about 20% for pharmaceuticals as compared to what is paid in the U.S. I think, Amber, was it your slide that showed the increase in pharmaceutical costs as a percentage of total expenditure? Any ideas from the panel on what we can do in the United States to control control pharmaceutical costs?
Well, I think it's unfortunate that the U.S. is paying for all of the research and development of pharmaceuticals, and the rest of the world, essentially, we're paying for that. So we are paying more than other countries are, and they are benefiting from the fact that Americans are paying for that. But I don't know in terms of solutions, I don't actually see that with the aging population, that being ameliorated anytime soon.
So I would just make the comment that that the pharmaceutical companies would like us to think that the United States is paying for all the research and development, but studies have shown that research and development is alive and well in Europe and doing quite well, despite the fact that Europeans pay tremendously less for their pharmaceutical drugs. Everyone else in a single-payer system pays less because the rates that the single-payer entity negotiates with the pharmaceutical companies are simply lower. There is an example in the United States that's pretty glaring, and something that we can do to current Medicare right now, which is when President Bush expanded Medicare by adding Part D drug coverage, which was a tremendous thing to do. The trade-off was that the pharma lobbyists were able to get a clause in there where the federal Medicare is prohibited from negotiating discounts with the pharmaceutical companies. Unlike, for instance, the Veterans Administration, also a government agency that quite clearly is able to negotiate those discounts. So if you're getting drugs, if the United States is buying drugs through the VA system from pharmaceutical companies, they're paying much lower rates. So of course, that little inconsistency needs to be fixed by Congress at some point.
Any other comments? Thank you. I'm going to rephrase this question for the benefit of the person that wrote it, just to keep it as a little less volatile, I suppose. Considering, and I am adding this is my paraphrase, considering the profits that were made by private insurance companies this last year, which were record-setting, what role should insurance companies appropriately have under the Affordable Care Act going forward? Is there, are insurance companies in the way of progress? Or do we need to reformat the relationship that we have with private insurance companies under the Affordable Care Act going forward?
So the Affordable Care Act created medical loss ratios that says insurance companies cannot keep over, it's an 80-20 ratio. So they're only allowed to spend a certain amount on admin, and what they don't spend, whatever they earn above that, they have to return back to consumers. So that was a good move in the right direction. And we have seen some insurers give back money to consumers.
Yeah, it's hard to how should I say this? It's hard to be very positive about those kind of profits when it's very difficult for most of us to manage our own budgets. I think there is something, well, for one thing, health plans are trying to become more engaged in quality and doing more to try and engage both hospitals and physician groups to try and find ways to partner with them. Now they're doing it, I think, out of a sense of panic and out of a sense of concern, because with the electronic systems we have in play, there are some real opportunities for hospitals and physicians to work together, and maybe for insurers to work together as well, but to take away a lot of the inefficiencies that have been in the past. And that's, for me, the challenging and the encouraging part of what we're seeing in the future here as we become more electronic-based, is that we do have the ability to share a lot of information, and we do have the ability to do a lot of managing of patients electronically so that we can do a more efficient job, and actually I think we can save the system quite a bit of money. whether the insurance companies turn out to be a good partner or an evil partner, as they have often been in the past, is still hard to know. They think they've gone through they've had a conversion that's not quite, it hasn't been acted out yet.
Thank you. We're going to have to end on this question, and I think we'll need to set the stage for it a little bit. How much of the physician shortage is attributed to physicians not wanting to move to rural areas? Are physicians overrepresented in urban areas? And if that was more equitably distributed, would there be a difference?
So what we do know is that whether you're a physician, a nurse practitioner, a physician assistant, pharmacist, whether you work, where you work is very similar. So there is a tendency for all of those professions to aggregate in urban areas. It is, in California, there's a physician shortage generally. It's not just in rural communities, but it's more pronounced in rural communities. In rural communities, it's increasingly difficult to get specialty care, and we're seeing more and more of the time we're having to refer people out of our area, something that Mr. Wiltermood and I find very distasteful, but that's unfortunately sometimes the case. And so I think we're going to see a challenge as a community of trying to make sure that we can attract financially, socially, and bring new young professionals into the community in a way that we haven't been able to do up to now.
Any other last comments?
California also has, is one of the few states that has a ban on the corporate practice of medicine, so hospitals cannot employ physicians. So that's another solution that's oftentimes raised every few years as a solution as we start to learn that physicians actually, they would like to have more work-life balance, they want more time off, they want to have a regular schedule. So that is a solution that has been posed and is working well in other states. Additionally, the Affordable Care Act tried to address this by having the payment, the physician payment bump for the 2 years because they wanted to attract physicians to be able to serve the newly eligible Medi-Cal population. That wasn't extended. Unfortunately, it didn't work out the way they had hoped. Many physicians were able to take that money and then retire. So we're also examining perhaps scope of service. Are there other professions that can provide different levels of service to folks to meet the demand of folks that are newly insured? So there are a lot of potential options, policy options out there that are kicked around every few years, and we'll see as access becomes even more of an issue, which ones stick in the near future.
I really appreciate you saw me pause for a second. Like, oh,
As you can tell, there's a little bit of debate about this, but Dr. Skeen, I'll give you the last word, and we'll just avoid the conflict altogether.
No, I would just like to say that I agree with Dr. Thorp that our healthcare system and the challenges of our healthcare system have remained in the news ever since at least 2009, which is going on a long time now. I personally think that's really an excellent thing, and I encourage everyone to stay involved, to stay educated on reform, and keep pushing this process forward.
Thank you very much. Well, in closing, give a hand to the panelists. Thank you very much. I'd like to thank Nicole Johansson and her staff and the Enloe conference staff for putting this together. And thank you for your time and attention, and thanks to our listening audience. And we're adjourned.